Next speaker is Dr. Arindam Ray. I'll welcome him to the podium. Dr. Arindam Ray is a vaccine delivery senior program officer at the Bill and Melinda Gates Foundation. Previously, he has worked with the World Health Organization as a national focal point for monitoring and evaluation and surveillance medical officer for over a decade. Dr. Ray will be also joining us later in our panel discussion. So right now, I will invite him to deliver his talk.
Good morning. From the molecular mystery to, some mundane business, and that's a business where you need to kiss 1,000 frogs to find your prince. So that's the story. So there is, so Dr. Devajyoti told that he was an outlier, but probably I am. Among all the brilliant scientific minds, I will be telling something which is not so much related to science and technology, but actually how you translate it and what's our experience. So most of these things are culled from our internal learnings, imbibed through interactions with the industry. So I will have to sanitize some of the things because there are actually companies and peoples behind those. So some of the lessons we will talk about from our investments and those interactions, and then how that modified or what we learned about how that changed our diagnostics development approach, and maybe a very quick example from the TB diagnostics in the India context, keeping with the main focus here, how we can develop low-cost diagnostics for affordable healthcare. So there is a high-risk failure. I mean, probably it is safe to say now that compared to the pharma industry or, say, vaccine development industry, the diagnostic development may not be that attractive to the investors because of very high uncertainty and low, probability on the return. So some of the things, it starts from the discovery phase, and then you go to phase 0 and phase 1, and then to the trial, phase 1, 2, 3. So these activities actually, what we learned that the first idea how to map the needs and the priorities of the targeted user or the clientele, that's the key. And that's where you actually come out with the kind of the technology idea which can solve the very specific problem. And then how you apply it for the biological materials. Now, one of the key uncertainty comes from that we are dealing with a lot of weightware as well as hardware and software. And that does not always go with kind of a very structured algorithm process. There are surprises in the steps. And then how you integrate the technology to kind of, the assay integration, so that you can actually have a feasible product. The kind of dollar and time that you are seeing, that also kind of reflective of inherent challenges. And it's, I would say, a little bit dated right now because of the acceleration that has happened in case of COVID. But somehow this is giving a ballpark estimates. Now going forward with the phase 1, where you define the design, then you lock the design, and then you validate it that it would work, and then you go for the kind of commercialization. And again, it's not a kind of a cheap to do that. And the risk appetite for, at least from in the public sector would be very low to go for those kind of developments, though the dividend is very high if we think of the overall value proposition. But how you redefine that value proposition, that's the case here. Probably we can come back to those topics in the panel discussion as well. But suffice to say that initially, for the developer, for the manufacturer, and for the investors, usually it starts with kind of, individual diseases or the individuals who are suffering from. So it's either a kind of a B2C or B2B kind of a value proposition that you start working with, which would vary depending on the disease prevalence as we're discussing right now. But if you think of kind of at scale implementation of diagnostics for, say, screening, for, say, surveillance, pandemic, forced that kind of a situation in a very short span of time. And that was the motivation for the acceleration, because you needed to respond to that. But you means all of us, but particularly, the policymakers and the public sector stakeholders, probably there is misaligned incentive structure into thinking of that. So we did some internal analysis of 28 companies. I cannot, of course, give you the, all the details, but I can just glean you the very specific learnings which we learned from there. So some of these companies are actually success commercially. So we wanted to learn that what they did right that actually made them successful in translating the technology into a marketable product, and which actually gained a kind of a surviving market share. The second group of companies were kind of what we call zombies, because they still existed. They tried to exist, but it's a survival struggle. It's a continuous struggle. It's a kind of a, very difficult to manage even at a break-even point. And the third are, of course, the ventures which had to shut their shop quite early. So you are seeing kind of these 5 categories of things are coming up. So 70% of the reasons you are saying that technology doesn't meet the user or the clinical need, the problem that you like to solve for. 10% is the product prototype doesn't work in real case, in real life situations. And another 10% is product was not designed properly when you like to manufacture it at scale. And then 5% is clinical trials didn't meet minimum clinical performance, and rest is the market adoption. I think the basic takeaway point here is that 70% is actually when you conceptualize the initial, the product that this you like to go for to solve this particular clinical unmet need. Probably didn't do the right kind of mapping the needs and priorities and the feasibility. So that's where the core problem lies. So 3 main lessons we learned. One is understanding upfront the use cases. Who are your customers and what exactly we like to develop. And as you know, the foundations, just quoting Warren Buffett, we like to swing for the fences. So choose the most difficult areas for the highest possible impact. So that means you need to go for, kind of unsolvable problems in most hard-to-reach terrains, and that's in the low middle-income countries. So, as Professor Devajyoti was highlighting, you need tailored solutions for those kind of geographies, not exactly made for the developed country solutions. That's where our focus lied. And if you, many of the early developers are actually coming from kind of a developed country mindset in Europe and USA. If they fail to actually decipher that mystery, that what it will take to actually implement it in the LMICs, then you may have a brilliant product, but which may not have a market. Then the technology development, as we are discussing, is inherently risky, and in last, say, 5 to 7 years, more than or near about 4,000 technologies that we reviewed, only a few advanced to the product level. To Ebola things, again, that's a kind of, you can say, mini pandemic kind of situation. I mean, should not use pandemic, but it's a kind of a crisis situation for a kind of a geography which thankfully was much more limited than what COVID has affected. But always when there is a kind of, crisis, emergency, we did something extraordinary, pulling together all the intellectual and funding resources to find a kind of a feasible solutions which can work. That kind of urgency we cannot hold on to in usual normal life settings. That's one of the failures that why we are not proceeding for, say, other communicable, which is our main focus, and probably even non-communicable disease diagnostics. Product development risk can be mitigated if we follow the best practices. If we follow those successful companies which did something very basic, but they did it in right and proper way. So one of the, most valuable thing to have is a leadership who can navigate through these kind of implementation challenges, who can take the right calls. And that actually sounds very kind of a cliche, but that's, we have found, unfortunately, one of the most important factors which makes the difference between failure and success. And of course, the at-scale capacity to develop or to manufacture will be another important thing. I'm not going through each boxes because of paucity of time, but you can quickly scan through that. These are the some of the development phase options or I would say kind of strategic choices that we need to make. And there are, if we don't do that, there are examples of failures, very messy failures, and that means we are losing valuable dollars. There is an opportunity cost which can be actually focused in other potential successful things. In our internal thinking, what we do some kind of a risk matrix. That's what's the severity of the risk, and it's a very simple Steve Covey kind of a thing, and what's the likelihood of that risk. So if your likelihood is also high and the risk is a kind of a make or break thing, of course you need to find a kind of a mitigation, otherwise it's a no-go decision. So that kind of a nodal matrix thing need to have place, particularly for the startups and entrepreneurs who are thinking that their brilliant technology will be successful, but probably these are some of the things that you need to go through. At the very top, you are saying that NCO, CO, VP, R&D, and head of commercial have 5+ years successful product development. I just like to reiterate one point. We have seen, without naming any body or entity, we have seen very brilliant technology startups who actually started with much more enthusiasm, but just because they didn't have anybody who has experience of running diagnostics companies. The experience of running a pharma company, or say even biosimilar company or vaccine company, probably will not be that effective if you don't have the experience of running a diagnostic company. And just quick example. So this is a practical examples of a successful TB diagnostic company. Because they are grantee, I'm not naming them. But if you look through what it has been found, that 2/3 of the time is actually the sample preparation. That takes your time and cost. not the the actual amplification and getting the results. So these steps that you have to follow through the value chain of the sample preparation, you need the technology and the process rationalization there. And of course, the other quality control, software parameters, everything need to fix that. And when they did that, I mean, it became a successful product, of course, first in the, in the LMIC context. I'll give a last quick example from a TB diagnostics that we supported one of our grantees, Chai, to actually do it. So basically in and this is a non-technology intervention which can actually drive the cost. So first one was a kind of a technology intervention where you are rationalizing and simplifying the process. Here, what they simply did, in 2013, the TB test volumes was kind of around, say, 28,000 per annum. Now, because of this intervention, it increases almost 10 times over the years, and now it's further expanding to other disease fields. So basically, they formed a consortium of the service providers, the diagnostic service providers, to have a ceiling on the price. And just to give you a quick example, say, for the NAT, I mean, they thought that, say, 2,000 will be kind of a rational ceiling based on the cost of goods analysis. Now, how they could drive it? So it's a kind of a example of a positive coupling, and also going into an agreement, as you see on the left side, with the manufacturer and distributors who supply the reagents and the equipments at an affordable price to the lab service providers, so that then lab service providers can bring down their cost. That is one intervention. The second intervention, at the same time in parallel, you actually promote the adoption of tests. So what you do, you get the government to make the notification of TB cases mandatory. So that expands your case volumes. You also ban the so-called blood serology, which doesn't make any sense for TB. Those kind of tests. So the labs are busy on doing those and wasting resources and misaligning the public health priorities. So when you have those kind of regulatory framework in places, that makes it easier even for the private provider to actually report cases, and that drives the volume. So from a high price, low volume market, you shift it to a low price, high volume market. It's already published, most of the learning, so you can quickly check. Sharang Deo and his team, I mean, there is a lot of collaborators as well. But what probably requires to expand this kind of model and sustain it is a continuous, innovative private sector engagement. Thank you.
Thank you, Dr. Ray, for that wonderful talk. So in interest of time, we hope it is okay if we skip questions,
Yes, okay.
and attendees can discuss with you offline. Thank you. I request Devanshi to please introduce.